Office treatment of hemorrhoids by Praveen Gupta, Nagpur, India. Local treatment of hemorrhoids consists of ointment, cream, gel, suppository, foams, and pad. More than one type of ingredients are present. Hydrotherapy in the form of sitz bath. Then drug therapy including euphorbia prostrata, flavonoid derivative, and calcium dobilicillate. All these act as venotoner, venoprotective. In the modern times, the trend is to resort to fast and painless procedure in the office under local anesthesia. They are effective in treating early grades of hemorrhoid. It depends on experience of the treating surgeon. The aim of such treatment should be induction of fibrosis to replace the hemorrhoidal cushion back to their normal position. Only internal hemorrhoid should be treated. The first one is sclerotherapy, which causes aseptic inflammation, and the hemorrhoid heals by scarring by getting them attached to the underlying muscles. To the sclerotherapy, different sclerosant, phenol in oil, ethanolamine oleate, sodium iodide, tetrazidicyl sulfate, polidocanal, or alta. They cause non-invasive sclerotherapy. The advantage: useful for non-prolapsing, easy to perform, well tolerated, but can cause discomfort, bleeding, infective complication, and high recurrence rate. Rubber band ligation is the most favored for early grades. It encircles the base of the hemorrhoid with a tight rubber band, and the tissue cutoff is replaced by an ulcer. Now, a suction band ligator is also available, which facilitates easy bending. It is a multi-ligator and device is automatically reloadable. Advantages: useful for grade 1 to 3 hemorrhoids, easy to perform, can be done in office but can lead to intolerance, slippage, severe pain, bleeding, infective complications. Then treatment of hemorrhoids using thermal energy, which cause inflammation and scarring. Pain is less compared to band ligation. Also, the bleeding is less. Then the freezing and laser treatment. Freezing is called as cryotherapy using nitrous oxide or carbon dioxide. Laser uses CO2, argon, diode, etc. Then comes the infrared coagulation. It's a photocoagulation. No anesthesia needed. It's painless. 3 to 4 shots are given as spot weld but requires repeated sittings. Similarly, endoscopic coagulation of hemorrhoid, same device but can be done through the endoscope, so more precise. Then comes the bipolar electrosurgical device, which coagulates the hemorrhoid in situ. Tissue damage is quite high with fibrosis and anal narrowing. Similarly, RFITT is similar to that. Then comes the radiofrequency surgery, high frequency energy wave with minimal lateral thermal damage and least scarring. Then comes the HET bipolar system, which is a tissue ligation device for grade 1 and grade 2, modified anoscope with a tissue ligating bipolar forceps. Hemorrhoidolysis is ultralight or direct current electrotherapy, which causes a chemical reaction, changes the hemorrhoidal tissue to sodium hydroxide when current is applied. Then comes the Hemorpex procedure, which is a single use device dearterizing hemorrhoidopexy under minimal anesthesia for grade 2 or 3 hemorrhoids. So this is again a type of mucopexy of hemorrhoid. This device has got a lateral window which then comes the Doppler guided hemorrhoidal artery ligation, which has got a specific endoscope which detect the hemorrhoid and they can be ligated. On the same basis, Doppler guided hemorrhoidal laser procedures are done where the hemorrhoids are ablated with lasers. Then atomizing hemorrhoid, which removes hemorrhoid by atomizing through an electric current, and the hemorrhoids are converted into smoke or fumes into aerosol of carbon and water molecule and excise and vaporize one or more cell layers of the hemorrhoid. Now a question arises as to which is better than the other. None is greatly superior to other, but failure of one method cannot be taken to predict the efficacy of another. The obvious question which is raised is which equipment is necessary. But if you don't have all the instruments, then the risk of under treatment or no treatment can be there. Grade 1 can be treated with control of constipation, drugs, high fiber diet. Grade 2 requires sclerotherapy. So the first line of therapy should be conservative, including fluid and fiber. 1 and 2 grades by office-based therapy. Operative therapy for symptomatic grade 2 and for grade 3. Surgery should be considered only as a last resort, restricted to failures of office treatment. However, office treatment avoids painful wounds. So each practitioner therefore must be in a position to offer the greatest possible range of treatment option in order not to be slave to one particular method with risk of inadequate treatment. So all the options should be given to the patient.